Today we are going to talk about puberty. And the puberty is a very fascinating subject, and it's quite actually wide spectrum also. So I'll try just to simplify and focus on just a particular part of puberty, which you'll see now. Thank you. Right. So what is the process of puberty? And then we'll talk about a few cases of abnormal puberty. Puberty is defined historically as the transition from sexual immaturity to sexual maturity. It involves two main physiological events. The gonadarche, which is the activation of the hypothalamo-pituitary gonadal function, namely production of LH and FSH, going to the testes and the ovaries, and so forth. But there's another component that is not much talked about, which is adrenarche, which happens usually like 2 years before puberty. There is a lot of talking about what is the role of adrenarche. It is like another primer, a priming event, preparing the body for the actual puberty. But when people talk about puberty, they actually talk about gonadarche. The definition of puberty is revisited, you see, by psychologists, psychiatrists, social, activists, and so on. It is just, we focus as doctors on the biological part of puberty, but we know that there is a lot more than just the physical part. There is the cognitive part, the operational thought, the formal operational thought, and we know from religion, from our religion, and this is where the people are accountable for what they do when you get into puberty. There is also the psychosocial stages of adolescence with all its storms and stresses and the problems. So novel insights have moved from just being a physical act to say that it's a multidimensional interacting suite of physical as well as senso-emotional maturation process. So is it possible that one day that we will see this, when we treat our pubertal children, especially those who have problems of puberty, abnormal puberty, that we include other disciplines at the same time? The normal pubertal development, there is what we call the mini puberty of infancy, then a period of just, pre-puberty, as we know, and then we go into the actual puberty. This slide here shows, that if you go fetal, neonatal, childhood, adolescence, and adulthood, and this is the gonadal activity on the left side. The black line talks about gonadal activity as from fetal life. And you can see that there's quite a surge of gonadal activation that drops down a little bit at birth, only to surge again after birth in the neonatal period, and the effect lasts about 3 to 6 months. This is followed by a period of quiescency, and then when we get into normal puberty, the gonadal axis goes up. And this is where things go wrong. If you either, like the blue one will tell you, I beg your pardon, yes, the blue one will tell you if I have delayed puberty. If I have delayed puberty, this is the green one. The blue one is if I have partial puberty or problems, incomplete. And then the lower one is absent puberty. So activation of the hypothalamo-gonadal axis in the neonatal period, increase the gonadotrophins. It allows for the development of genital organs. More studies are done in boys, in males, and there is evidence. There's a lot of work on the size of testes and how this mini puberty of infancy affects boys. It is not as clear as in girls. It creates the basis for future fertility, and it provides a window for diagnosis of hypogonadotrophic hypogonadism. Actually, there is some very exciting information here that when you diagnose hypogonadotrophic hypogonadism at such an age, there is a room now for treating these babies, right, with preparations, LH and FSH, with a resultant improvement in their gonadal function. But this is another topic. Now, let's just agree that, you start puberty in the girls on the left, boys on the right. Girls start at 8 years. Anything below 8 years is abnormal. Boys start at 9. Anything below 9 years in boys is abnormal, right? And anything beyond 13 years, if a girl does not have any secondary sexual characteristics by the age of 13, this is delayed puberty in girls. And the same goes to boys, only that it's in 14. And you notice here, very important, this the top block here, breast budding. Breast budding is the hallmark of normal puberty, what we call central puberty, the normal puberty. Anything else, any deviation from this cascade means abnormal puberty. In the boys, the most important thing is the testes. So sometimes you get a boy with pubic hair and the axillary hair and a bit of voice change, and then you look at the testes. They are prepubertal. Pubertal testis measures anything less than 4. Up to 3 milliliter will be pubertal testis. When they become to 4, this is the herald of puberty. Now, of course, girls grow earlier than boys. You can see the growth spurt is between 11 and 13, while the growth spurt here has been 13 to 15, 16. Issues arising with puberty, anemia, mainly from menstruation. Gynecomastia in boys is not uncommon. We see actually more and more of it now, especially with obesity, and you have to make a differentiation between gynecomastia and lipomastia, because some obese or overweight children will come, but you have to have a true breast tissue to call it gynecomastia. Acne, psychological changes, musculoskeletal injuries, they are active and they are in the phase of rapid growth, so you get prone to more injuries, ligaments and stuff. Gynecological consequences, of course, myopia, scoliosis, and sexually transmitted diseases in active adolescents. Now, let's go back to our part. Puberty as a biological puzzle. They're always saying, idiopathic. We always say precocious puberty, especially in girls, is idiopathic. And people actually are, up till now, are not able to tell what is the exact trigger. How does the body just decide now? And this is going and forget about the abnormal ones, but normal puberty in most of the population, it's follow the same rhythm. By 11, you see, girls are almost there. By 13, 14, boys are there. What triggers it? Right, up till now, we still need a lot more work, but some light has been thrown. Recently, like about 7-8 years ago, there is, they have discovered what we call the kisspeptin. They call it the kisspeptin, right? And it says that this kisspeptin, is a regulatory of it's actually the one that goes onto the hypothalamus to stimulate the release of GnRH, which in turn stimulates the pituitary gland to produce FH and LH, either testes or ovaries, and then of course we get the negative feedback from the sex steroids. Kisspeptin, a family of neuropeptide, it is, as I said, important for the initiation of puberty, and now the research has shown that abnormalities in kisspeptin can be accompanied with abnormalities, right, of puberty. So clinically, clinical relevance, in center precocious puberty, there are studies to show that mutations in KIS1R, it is on chromosome 1, right, are associated with precocious puberty. Now, genetics is coming more and more. And also, loss of function mutations in the KIS1R gene were first described in the consanguineous families isolated hypogonadotrophic hypogonadism. So here we are coming to more and more understanding. The good thing is, it's very promising that the current data supports the potential use of preparations that can alter this abnormal situations. Right, now let's see some cases. First, we have a male infant presented at 15 weeks of age having developed a number of dark, coarse scrotal hairs. during the preceding week. There were no other signs of andronization, and testes were of normal infant size. Any idea what it could be? Right. Investigations show that testosterone, normal testosterone concentration, normal androgen profile, everything else was fine. And then by 7 months of age, it has disappeared. Right, we go back to the mini-puberty. This can be just an exaggeration, normal variation of the mini-puberty, right? You might argue, so why this testosterone was normal? Because most likely that, you know, this because testosterone in mini-puberty is actually higher than the rest of the childhood period, and this triggered, you know, the formation of this, the appearance of hair, and then it came back to normal, and its effect lasted for a couple of months, and then disappeared. Right. Next, a 5-month-old girl referred to pediatric endocrinologist. Mother noted left breast development at 3 months of age, followed by right breast development, advised by her pediatrician to see endocrinologist urgently. No other abnormalities noted, thriving well, normal development. What did the diagnosis? Normal, okay, told normal, yeah? Right? Caused by stimulation from neonatal hormones, usually resolves spontaneously within a few weeks or month, persistent, does not carry pathologic significance, may be associated with witch milk, or what the calactoria, what you call witch milk. Practice point, assurance, which may not be easy. Sometimes you get the patient coming, has seen 2 or 3 doctors, and this goes for all the problems we have here. As I said, Dr. Salman was talking, you know, there is this, you know, trust or this an anxiety, and they want to be reassured continuously. Right, case 3, a 6-year-old girl presents to the pediatric clinic with 3-month history of appearance of pubic hair. This was noted around 7 months ago, but it was fine and sparse. Now it's turned to be curly and thick. Parents also noted that when she comes back from school, she has like an adult BO. Diagnosis? Huh? Adrenarche, all right. Are you sure? Anyway, now just a reminder, you see that anything below 8 years is abnormal. So the first question is this normal, abnormal? This is normal. And the second thing is this starting by breast budding? No, she only has pubic hair. So we have a problem here. So what is this, you know, about? She was born at 39 weeks, birth weight 2.2, normal development, weight and height on 25th percentile. Endocrine, prepubertal FSH, LH, estradiol, testosterone, TFT, born age normal, normal abdominal ultrasound, and the normal pelvic ultrasound. So, adrenarche, are you sure? Can you tell her she has, what are you going to tell parents? Don't worry, this is normal, that your child has pubic hair? Right. Now, let's just have a look at this. This is the different, this is like kind of an overview of, you know, abnormal puberty. It can be of precocious puberty. It can be central. It can be peripheral, whereby, you know, there's just sex steroids are going up for a number of reasons. And it can be benign, non-progressive variant. Thelarche, adrenarche, and menarche. This one, the benign non-progressive variant, is not associated with activation of the hypothalamo-pituitary gonadal axis. The only time when you get the proper cascade is with the activation of the HPA. Right. You've reached the diagnosis. Well, I know, but is that it? Are you 100% sure yourself? You want any more tests? Right. Let's just a reminder, you know, these the 3 zones, the zona glomerulosa, fasciculata, and reticularis, and here we have our adrenal steroids, you know, the androgens, 17-hydroxypregnenolone, dihydroepiandrostenedione, androstenedione, and then going to testosterone, which later can give you estrogen. Right. Adrenarche, you are right, but what is adrenarche? Adrenarche is the maturation increase in adrenal androgen production that normally becomes biochemically apparent at approximately 6 years in both girls and boys. Again, it has a role that is not very clear, but it is priming for the future puberty that will happen in 3 to 4 years from now. I've reached a diagnosis. Yes, you have. Right. Premature adrenarche, because adrenarche itself is adrenarche. You don't see it. If it comes out as pubarche, You call it premature adrenarche. Right. It's characterized by production of increasing amounts of weak androgens by the zona reticularis. These weak androgens are mostly responsible for the appearance of the pubic hair, and it causes the sebaceous gland and the epigram gland, you see, and so forth. Now, the increase in dihydroepiandrosterone sulfate is the most important marker. You do a test, the DHEAS, and it has been shown, right? This is a study, or actually not a study. It is a review by the Endocrine Society, right? And it shows that that DHEAS increase, as you can see here, it's 40 to 130. This girl had 135, and also her testosterone was on the high normal side. These are the two you look at, but the most important is DHEAS. And if you look at the DHEA, it goes very high up in adrenarche, the one next to it, but it is unstable, so you cannot rely on it in measuring. So you measure the DHEAS, amongst others, of course. Right, and this is just again a slide to show, the increase in the DHC in male and females, and you can see that, this goes up in the prepubertal stage. It has, it shouldn't go up beyond a certain level. Of course, in adrenarche, it goes right in much higher. So we always talk about adrenarche as a normal variant. Don't worry, ma'am, this is just, like we call, it is something physiological, normal, that just went a bit exaggerated to give you this pubic hair. However, everything else is fine. She is a girl of 6, and she's behaving like a girl of 6. She's in no danger of becoming like prematurely or going into puberty. Now we don't actually, we say this exactly, but we have to be more open because people read. I had a lady who actually gave me she was talking about everything, you see, even the incidence of abnormal MRI in a precocious puberty at the age of 8. The traditional, well, not traditional, if you have a girl with MRI below 6 years, of a girl with precocious puberty before 6 years of age, you do an MRI. If between 6 and 7 you decide 7 and 8, you really don't want to do it. And she was talking about the incidence of abnormal MRIs between 7 and 8 years of age, and that is 3%, which I didn't know, right? Anyway, it is associated with insulin resistant and later development of metabolic syndrome and the polycystic ovary syndrome. And it is also more common in small for date, as we know that small for date, of course, is associated with, the polycystic ovary. So we have to be careful. We have to explain to her. Now, premature adrenarche mostly present with pubarche, so the differential diagnosis is always in the peripheral puberty. Why? Because I don't have the cascade. Elevated DHEAS and the normal other endocrine investigations make the diagnosis, assurance, and follow-up. You must follow these children up. Now, we move to a more complex situation, right? Precocious puberty. Now, just to recap, again, central, peripheral, normal variants. As a general rule, girls with precocious puberty do not have a pathological cause in over 80%. And you relax when you see a girl with precocious puberty, which is not always, of course, true. But boys are mostly due to a pathological cause. Why? I'm not sure. Now, a 3-year-old male child presented with growth of pubic and axillary hair, enlargement of penis and facial acne for the last 5 months. On physical examination, his height is 3 standard deviations above, normal for age and parental height. Penile length is 5.8, testis 5.6. Remember we said prepubertal testes are less than 4. So once you get the testis 5 to 6 mils, you know this is going on. This is high hypothalamo-pituitary gonadal axis activation. FSH 1.5 and LH 9.1. The pubertal LH is less than 1. And in a lot of situations when we get children with precocious puberty or suspected precocious puberty, we do what we call the Lhrh stimulation test. So you get children presenting to you, but they have, and we'll talk about this in a minute, they have prepubertal levels, you challenge them, they either stay prepubertal or they shoot to pubertal levels. This boy has already come, he doesn't need an Lhrh test. He's already showing an LH of 9. Testosterone, again, very high. Thyroid function normal because hypothyroidism can cause precocious puberty. And adrenals and testis shows no pathology. Is he secreting from an adrenal tumor or testicular tumor or whatever? No. Have you reached the diagnosis? Do you want to do more tests? Huh? MRI of the brain, excellent, all right. So you want to do MRI of the brain, and this is what you find. No, this is the hypothalamus, and this is an over non-enhancing pedunculated hypothalamic mass arising from the tuber cinereum, 2 by 1 by 1, extending into suprasellar cyst. And this is hypothalamic hamartomas. Hypothalamic hamartomas, by the way, are diverse. There are different types, right? And not all of them can easily be resected, and not all of them cause precocious puberty. They are more the neurologists will tell you more, they are often associated with gelastic seizures, abnormal behavior, and developmental delay. It's one of the most causes of central precocious puberty, and it is generally observed in children under 3 years of age, in boys under 3 years of age. Most can happen in girls, but boys are much more common. Right. After 6 months of starting conservative medication with LHRH analogs, everything goes fine. But this is not the definitive treatment, of course. And definitive treatment is surgical removal. And there is a lot of recent beautiful advances in microsurgery and laser ablation and so on. I followed a child in 2003 that was not resectable. The tumor was non-resectable, and I followed him up till 2010. And he was on LHRH analogs with good conservative treatment, and he didn't have other neurological manifestations. Right, now we move from the boy to give an example of the girls. Again, just I know it's exhausting to you, but a reminder, we have the central, we have the peripheral, we have the benign non-variants. Right, now before we go into this next case, just girls, and the puberty. What is the impact of early puberty on girls? Well, in general, but we are mostly talking about girls. Oh, no, this is not I'm sorry, this is the one. Yeah, this is the one. A range of studies have noted the high risk of psychological, social, and behavioral problems in this population. In a study of 7,802 women, earlier age at menarche was, I'm not talking about true precocious puberty, was associated with a high risk of depressive symptoms and antisocial behavior, and which persisted till adulthood. I'm sure Dr. Tahir can tell us more about this later. Right. What this means for the pediatrician. Pediatricians must be sensitive to the psychological importance of puberty for early maturing girls and recognize the duration of its effects. Accordingly, early referral is highly recommended. And one of the main problems Dr. Saman was talking about is really the turnover of expats, turnover of doctors, turnover of patients, where we don't have the link. Ideally speaking, a lot of what I'm seeing here, I'm telling you here, can be joint care. Yani you see the child, you diagnose, say, pubarche, and you send them back to his pediatrician. The pediatrician follows up, and then if there is any red flags, can come back again, which doesn't happen here. Right, a 6.5-year-old girl referred by her pediatrician with early breast development. No past medical history of note, normal growth and development, mild acceleration in height attainment observed over the last year. So, what is the differential diagnosis? Give me two. Breast development in a 6.5-year-old girl. Take it back. Take it back, I don't need it. What is the differential diagnosis? Breast development in a 6.5-year-old girl. One, Lhrh or precocious puberty. Excellent, right. Okay. Precocious puberty versus premature Lhrh. How do you make the differentiation? How to make, you see which is which? Huh? Bone age. What else? Is it enough? H. CH? You mean LHRH and the stuff? Of course. Okay. It is of utmost importance to make the distinction. Why? Why is it so important to make the distinction? Because I'll tell you. The premature Lhrh is highest in the first year of life, as we saw before, and it goes back about the 5 to 6 years. It represents what we call an immediate intermediary state between true precocious puberty and the simple premature Lhrh. And this is why people has coined terms like Lhrh variant, non-classical premature Lhrh to this group of children, right? But let's come to this again, you know. Precocious puberty is too much too soon, yeah? And we said less than 8 years in girls and 9 in boys. Early epiphyseal maturation, compromised final height, and believe me, compromised final height is such a big psychological trauma. Yani we get girls who come out of the clinic in tears. Why? Because they came looking for hope. And interestingly enough, a lot of them come after menarche. It's amazing. We have been blah, 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 but we were told you see the growth hormone. How old are you? I'm 12. What is your height? 145 centimeters. Right? And then you start to you see the computer and make calculations, and you say, well, you have another 4 centimeters, 3 centimeters. And they don't like it, they hate it. And what is more depressing is some of them come on growth hormone prescribed by other doctors. And I really apologize for saying this, but it is true. So, and most of them are not under insurance, because insurance, you know how strict they are when it comes to growth hormone treatment. So what can you do? So it is of utmost importance to treat early precocious puberty. Yeah, but it is equally important not to treat premature Lhrh, because you are, how much you're going to put them on the LHRH analogs. The injection is 2,000 dirhams every 3 months. And a lot of these expats do not have this kind of money, but they do it. Right. So center, I'm going to put the clock back, make it 3 minutes, not 1 minute. So central precocious puberty versus premature Lhrh. Let's have 2 scenarios. The same girl. Let's have 2 scenarios. With a scenario on the left, she's a premature Lhrh. She's a girl, she's going to stay as a girl. The other one, no. In 2 or 3 years' time, she'll be the young lady. Right, here we are. This is an excellent study done in 2008, and it has 87 patients on the left through precocious puberty and 22 patients with premature Lhrh. And they looked at what are the significant variables that can make you as a physician confident or almost confident in saying this is, premature Lhrh or precocious puberty. Obviously, if you make a decision now, you follow them up. And if you follow them up and you find that at any time, the PT, what you consider PT, is moving to be central precocious puberty, the bone age is very important. The peak LH, right, as you can see, after stimulation, right, 12 in precocious puberty, 3.4 in PT, and then, and this is really important, the peak LH to peak FSH ratio. When this is high, this is precocious puberty, but in premature Lhrh, it doesn't go that high. LH is the marker, really, of central precocious puberty. So management, making the correct diagnosis, assurance follow-up, assurance follow-up, assurance follow-up, because you follow them up for a good few years. And even you see when they start puberty at 9, because a lot of them start puberty early, parents are not happy. Yeah, by 9 years, 9.5, she's starting to have the changes. Oh, no, treat doctor. I don't want her to be short. Right? And of course, if she, at any time, the small population that will shift to precocious puberty to treat, precocious puberty, of course, underlying cause, but LH analogs are the mainstay. Now, you went to consult your pediatric endocrinologist, progressive secondary sexual characteristics, increasing growth velocity or bone age coming to become abnormal. Challenges in management, insurance approval to carry out investigation and treatment. We find it very difficult sometimes to carry out the investigations because they are expensive. When to do MRI in girls. Difficulty in assuring parents medical shopping. You get people with files like this, wallahi. Yani seeing 3 or 4 endocrinologists coming like this over 2 years' time. Follow-up and default rate, as we talked about, the high default rate, psychological impact on the child and treatment modalities, concerns, cost and side effects. The LHRH analogs, it's what we call the selective medical hypophysectomy, are proven to really work very well. And they have other effects, extra pituitary, that's why they are used in breast and ovarian cancer. They are generally have no big deal, they cause, puberty recovers 1 year after, you stop in most of the cases. No abnormalities in productive function. Bone mineral density decreases during puberty but goes back to normal. Accretion of bone is normal. High prevalence of polycystic ovarian syndrome. This is partly true. I'm finishing. Decrease in psychosocial problems. And the summary is, puberty is fascinating. Definition is revisited. New insights in genetics are going to open a window for further treatments. Abnormalities of puberty range from normal benign variants to more serious peripheral and central forms, making the right diagnosis crucial and management to avoid both delay in treatment or unnecessary. Thank you very much.